Now, let's talk about lung consolidation. If the alveoli and small airways fill with dense material, the lung is said to be consolidated. It's important to be aware that consolidation does not always mean that there is infection. And the small airways may fill with material other than pus, as in pneumonia, such as maybe fluid, like in pulmonary edema, blood, or even chemicals such as fluid from the gastrointestinal tract, like an aspiration, um, or even cells such as cancer. They all look very similar, and the clinical information will often help to guide the diagnosis. However, sometimes you can get consolidation of an entire lobe, and that's probably more classical of either an aspiration or community or a hospital acquired pneumonia. Um, but infiltrates themselves can be because of a number of reasons. Um, Now, when we describe a consolidation, you need to describe that um, there is a complete opacification, or if there are infiltrates within the lung fields. Now, if an area of the lung is said to be consolidated, it usually becomes dense and it becomes white. If the large airways are spared, they are of relatively low density. So say for example the bronchi are spared, then the bronchi will still appear to be a bit more black, as is particularly visualized in this X-ray where the right middle lobe looks like it's consolidated, and it appears to be white and dense, but the major airways within the right middle lobe are not consolidated, and they appear a little bit more on the black side. And this is nothing but what is called as an air bronchogram, and that is very classical of a consolidation. So if you see a dense white opacification of the lung fields, and if you see air bronchograms, it indicates that the lung is consolidated. Now, we've already talked about the causes for lung consolidation, but let's talk about some of the other things that you may visualize. Not complete opacification, but an incomplete opacification, or maybe what is called commonly as pulmonary infiltrates. A pulmonary infiltrate is a substance which is denser than air, such as either pus, blood, protein, which lingers around in the parenchyma of the lungs. Now, it is it is considered to be a context-dependent, non-specific, and imprecise descriptive term when used in radiology reports. It may indicate either pus, again the same things, either pus, blood, protein, fluid, cancer, or anything of that sort. And therefore, the differential diagnoses are quite varied. Um, this particular differential diagnosis typically depends on the history of the patient, the localization of the pulmonary infiltrates, whether they're bilaterally symmetrical or whether unilateral, over their upper lobe, over their lower lobe, presence of certain patterns as to whether there are any nodules, fibrosis, or cavities, um, if there are any calcifications within the lung parenchyma, and what about the bronchovascular markings? The bronchovascular markings are normal or whether they are pronounced. And depending on these features, you will be able to give a differential diagnosis for the pulmonary infiltrates. As far as acutely developing infiltrates, depending on the history that has been provided to you, if an acutely developing lung infiltrates could either be pulmonary edema, they could be from aspiration pneumonia, or they could predominantly be from community or hospital acquired pneumonia, as well as hemorrhage within the lung parenchyma. The pulmonary edema as such will classically present with bilateral pulmonary infiltrates, which are symmetrical in nature. Um, it may sometimes give what is called as a bat swing appearance. We'll talk about that in a few minutes. There is also an increase in the bronchovascular markings, and there will be upper lobe diversions, as well as you may be able to visualize that the heart shadow looks particularly large, which means there's cardiomegaly. And on a chest X-ray, there could be other features of pulmonary edema, such as the presence of capitalization of the pulmonary vessels, curly B lines, septal lines, or peribronchial cuffing, or even sometimes you can see air bronchograms within the pulmonary edema, but this indicates that there is significantly dense infiltrates within the alveoli, indicating that there's a lot of pulmonary edema in this particular patient. Now, acute onset bilateral lung infiltrates with uh, can also acute onset lung infiltrates could also be because of aspiration or even community or hospital acquired pneumonia, and these usually present on a unilateral side. The lung, obviously, lung infiltrates would be depending upon which lobe is infected or which lobe is infiltrated with infection. And like in this particular case, there's the right middle lobe is particularly dense, and there is however, it's not as confluent as we saw in the earlier picture with consolidation, where there is a complete whiteout of that of right middle lobe. In this case, it looks more like a multiple infiltrates which have become a little bit more confluent in nature. Aspiration pneumonia is such as on most occasions it is because of a direct chemical insult, and the pulmonary response to aspiration depends on the type of the aspirate as well as the pH and the volume of aspirate. And in most cases, the initial damage is all because of chemical infiltrates, and later on, as there is further establishment of damage, this can result in secondary infection, and this can cause what is called as an aspiration pneumonia. The chest X-ray pretty much demonstrates the same finding of airspace opacification in a lobar or segmental distribution. And on occasion, the airspace opacification may be bilateral, but is usually perihilar, and on most occasions, it is asymmetric. Um, Radiographically, when you follow up these patients, if it's only an aspiration pneumonitis, in those situations, the infiltrates will start improving by the end of the third day. If they haven't really improved or they have worsened, then it indicates the presence of probably a secondary infection. Pulmonary edema. Pulmonary edema is pretty much secondary to accumulation of fluid in the lung interstitium or alveolar space, and it's frequently seen as well as a common cause of oxygen desaturation in the intensive care unit patients. There are lots of mechanisms that have been described. I'm not going to go into much in the way of description of um, the causes and the mechanisms of pulmonary edema. Uh, but the two classical patterns of description of pulmonary edema include an interstitial pulmonary edema, which occurs because of fluid collection in the lung interstitial space and usually develops when the pulmonary venous pressure rises to around 25 to 30 millimeters of mercury. And this usually comes up before, these interstitial infiltrates can be well visualized way before you see clinical signs and symptoms in the patient. And radiographic signs that may indicate the presence of interstitial pulmonary edema include large pulmonary vessels, appearance of septal lines, curly B lines, as well as interlobar septal thickening. On the other hand, alveolar pulmonary edema um, indicates the presence of fluid within the alveolar spaces, indicating the presence of an alveolar airspace opacification. And this usually appears bilaterally in a symmetrical fashion. There's always a bat swing appearance associated with it, which means these infiltrates are more in the perihilar region and get less denser as they go peripherally, indicating and presenting like a bat swing appearance. And the airspace opacification, as the amount of fluid within the lung within the lung spaces become more in volume, there could be a homogeneous airspace opacification bilaterally. Now, acute onset bilateral pulmonary infiltrates with lack of increased bronchovascular markings could be because of a number of other reasons as well. And therefore, it's important for us to differentiate between cardiac versus a non-cardiac pulmonary edema. So there are a number of findings that would tell you that this is a cardiac pulmonary edema compared to a non-cardiac pulmonary edema. And the classical findings of peribronchial cuffing or curly B lines or cardiomegaly um, will indicate that an upper lobe diversion as well as the prominence of bronchovascular markings indicates that this is a cardiac edema and not a non-cardiac pulmonary edema. But there could be a number of other reasons why a patient might develop similar kind of pattern um, um, pattern with non-cardiogenic pulmonary edema, like for example, in patients with ARDS. It could also be because of infections such as the bacterial, viral, fungal infections such as the PJP pneumonia, adult respiratory distress syndrome, pulmonary hemorrhage, and the non-cardiogenic pulmonary edema can also be because of just fluid overload without a cardiogenic shock, because of, say, for example, renal failure, or in patients with sometimes you can get inhalational injury with bilateral lung infiltrates, aspiration pneumonia, as well as from drowning. And therefore it's important to look at the rest of the findings to say whether it's a cardiac or a non-cardiac pulmonary edema. If you don't have a cardiomegaly, pleural effusions, upper lobe diversion, septal lines, peribronchial cuffing, or basal edema, then in those situations you should consider the possibility of a non-cardiogenic pulmonary edema and give the differential diagnosis accordingly. So obviously within the ARDS pattern as well, there is no evidence of cardiomegaly, no upper lobe diversion, no peribronchial cuffing, and both. However, it's important to remember that patients with ARDS could also have heart failure, and therefore both conditions can coexist, and differentiating these conditions separately would be quite difficult, especially if the lungs are heavily consolidated and you've got um, four quadrant infiltrate, um, as in this particular patient, where you can't really tell what the heart shadow is and whether there is any cardiomegaly or not, or whether there is an upper lobe diversion or not, and therefore differentiation might be quite difficult. Now, when you're describing a chest X-ray of a patient with bilateral lung infiltrates, you could potentially describe. I will go back to the previous slide, and maybe we could describe this particular chest X-ray, and what we can basically say when you're describing this chest X-ray is that there is bilateral four quadrant infiltrate which is confluent, and there appears to be bilateral whiteout of both hemithoraces, right more than the left. The cardiac shadow is poorly visualized due to the surrounding pulmonary infiltrates. There is no shift of mediastinum as evidenced by the ECMO cannula, which stays on the right side of the vertebral column. The endotracheal tube appears to be close to the carina and maybe too far down the trachea. The nasogastric tube is in good position. This may suggest a pattern of either cardiogenic or non-cardiogenic pulmonary edema. Um, More likely to be cardiogenic, non-cardiogenic pulmonary edema, based on the fact that the patient looks like he's on a ECMO circuit, cause, and then we can give a differential diagnosis for a non-cardiogenic pulmonary edema, including infections such as bacterial, fungal, viral. It could be drowning, fluid overload, inhalational injuries, ARDS patterns, or um, or even pulmonary hemorrhage in hematological patients. Now, some of these patients, when you start talking about lung infiltrates, some of these patients can have what is called as a bibasal lung infiltrates. And these bibasal lung infiltrates could either be an acute interstitial pattern or they could be a chronic bibasilar infiltrates. And these lung infiltrates are no different than the ones that we have described earlier, but they are very much in independent lung zones, and they may depending on the history that has been provided to you, you may be able to differentiate between a chronic versus an acute interstitial patterns. And a chronic bibasilar infiltrates the main differential diagnoses include bronchiectasis, aspiration, diffuse interstitial pneumonitis, asbestosis, and scleroderma. While acute interstitial pneumonitis, the differential diagnoses include viral pneumonitis, uh, mycoplasma, and other atypical pneumonia, and PJP. In this particular X-ray, you can see that there is bilateral reticular infiltrates in both lower zones more than the upper zones, and this would give a pattern of a diffuse interstitial pneumonitis, depending on the patient's history. The interstitial lung disease as such usually present with a pattern of reticular infiltrates within the lung zones, and on occasions there may be other patterns such as cystic or fine nodular infiltrates. Chronicity of these lung infiltrates will usually result in fibrosis, and these fibrosis patterns again will be more dominant in the lower zones than the upper zones. The differential diagnosis for reticular pattern include edema, such as heart failure or fluid overload, interstitial pneumonitis such as PJP or mycoplasma, lymphangitic carcinoma, usual interstitial pneumonitis, or even drugs. Cystic disease, on the other hand, is very specific for Langerhans cell histiocytosis or pneumatoceles or even lymphocytic interstitial pneumonia, while fine nodular or nodular infiltrates can be classically seen in tuberculosis, sarcoidosis, or metastases. On occasions, you may be able to visualize cavities or cysts or hyperlucencies. So what is this? What is a cavity? A cavity is anything which is basically a hyperlucent structure within the lung fields, and a cavity usually has a thick wall, which means usually more than 3 millimeters in thickness. Cyst, on the other hand, is a lucency with a very thin wall, which is less than 3 millimeters in thickness. An emphysema, on the other hand, is lucency without a visible wall. Now, um, cavities are not uncommon to be seen even in consolidation in patients who are having pneumonia, as well as within lung cancer, and therefore cavities usually appear either within a mass or because of necrosis within a consolidation. And their differential diagnosis will include infections such as staphylococcal or Klebsiella infection, gram-negative infections, anaerobes in cases of aspiration, as well as tuberculosis and fungal infections. Neoplastic infiltrates, lung cancers, and metastases can also cavitate. Um, Similarly, vascular disease such as lung infarctions can on occasions uh, cavitate as well. Cyst can be seen with like congenital disease such as bronchogenic cyst or bulla or pneumatocoel, and then you can have multiple abnormalities or multiple cavities or cyst formation within the lung zones, and this may be either in relation to infections, neoplasm, collagen vascular disease, emphysema, or cystic lung disease. It's important to remember that you can on occasion see number of these cavities within a zone of consolidation, and these are called as lung abscesses. Let's have a look at lung abscesses. Lung abscess is a circumscribed collection of pus within the lung, and is obviously potentially life-threatening. On a chest X-ray, it will appear as a cavity with an air fluid level. This is obviously indicates that the X-ray has been an um, upright X-ray. A supine X-ray will result in the fluid evenly distributed throughout the cavity, and therefore would not give you an air fluid level, but an upright direct film would definitely give you an air fluid level. And on occasions, this may be very clearly seen, as in this particular patient where there's a large cavity in the right upper zone with an air fluid level and a thick walled cavity, and this um, is definitely a lung abscess. On occasions, the lung abscesses could be multiple and quite small, and they may be distributed within a zone of consolidation. It may be very difficult to visualize these lung abscesses.